So, good morning, everybody. I'm Dr. Christopher Williams, and this place was home for me for a long time. I'm a urological oncologist, which means I take care of cancers of the urinary system. And for 14 years, I was the director of urologic oncology here at UF Jacksonville, this institution. I was in charge of robotic surgery. I started that program here. And also I was in charge of cancer research in the Department of Urology as well. So this is like home to me. Back in March, I left here, and in May, I started my own practice called Urology Consultants. And in my practice, I do second opinions and sometimes first opinions of patients who are newly diagnosed with cancers of the urinary system, and they have questions, like you may have questions. And they come and sit down and talk to me, and because I'm not doing the big operations like I did for all these years, I say, look, I don't have a dog in the fight. I just want to help you. And so that's kind of what I do in my practice. So Dr. Ken Jones is a friend of mine, and he's a general surgeon. And when Pastor Johnson asked him to come talk, he said, well, I can, but this is kind of Chris's area, and it is. And so we're going to cover a lot of stuff today. And the other thing is, they told me they wanted me to talk about surgery of the kidney for kidney cancer, but there's some other things that we should talk about as well, and I'll introduce those into those as well. And I'll follow up some things that Jayla said as well. So if I double cover some things, just forgive me, because but I want to make sure that you understand, what I'm trying to get over. All right, I think we can advance this way. Yeah, all right. So I don't know if Jayla covered grading or not, but we're going to cover grading just a little bit. So the grade of cancer is basically how aggressive it looks under the microscope. I saw her slide about the biopsy and such. So basically, a grade 1 cell looks like a normal cell, except for just a little bit of abnormality, but it doesn't mean it's not cancer, but it's just not that aggressive. And then grade 2 cells start to look even less like a normal kidney cell, and they're a little bit more aggressive. Grade 3 looks very abnormal and probably is very aggressive, has potential to spread. Grade 4, even more abnormal. Sometimes grade 4 cells are so abnormal, they don't even look like normal tissue anymore, not even like kidney. Sometimes it's hard to tell what tissue it came from. And those are very aggressive, very likely to spread, okay? So grading is important. Staging is important. She mentioned staging. I heard her when she talked about that too. Staging is really important when it comes to surgery and other issues, other treatment options, I should say, as well. And just briefly for kidney cancer, stage 1 is a tumor that's less than 7 centimeters, but it's confined to the kidney. So like down there, not working. No, it was working last night. Oh well. So down on the bottom left down there, let me see if this works. This works. Should be a pointer that works for us. Yeah, there we go. So that one right there, you can see, of course, this isn't drawn to scale, but 7 centimeters. So this is a big tumor, but it's still within the confines of that kidney. So that's what stage 1 is. Stage 2 is bigger than 7 centimeters, but it's still within the confines of that kidney. Stage 3 is different though. It's starting to not be in the confines of the kidney. It's growing into the blood vessels. It may sometimes even grow into small lymphatic tissue right around the kidney, and that's considered stage 3. Stage 4, as Jayla mentioned, the cancer is no longer even in the region of the kidney. It's spread to other places in the body, bones, lungs, liver, all kinds of places, and also in lymph nodes at other places in the body. So stage 4, the cancer has gone away from the area where it used to be complete. So that's stage 4. Excuse me. Excuse me. All right, so active surveillance is a management strategy for kidney cancer. Jill, you didn't talk about that, did you? Okay, good. So not all cancers need to be removed or even treated, okay? And active surveillance is a strategy where you follow these tumors by CAT scan, MRIs, ultrasound over time to make sure that they're not changing, make sure they're not becoming more aggressive in terms of how they're getting bigger, or even changes within the tumor itself. And so sometimes active surveillance may consist of doing a biopsy to determine the aggressiveness of the cancer before you determine that you're going to watch it, okay? And you might say, well, where would you want to watch it? Well, there's some patient factors that we should talk about that may make us want to watch a tumor. So if somebody's very elderly, say they have less than a 5-year life expectancy, and that could be for lots of different reasons. Sometimes somebody is just so old that to put them through a big operation may not be the best thing. Sometimes they're very frail. Sometimes they have other medical problems that would make an operation too risky for them, such as like a really, really bad heart or bad lungs. The position that you have to put people in for surgery sometimes can make it very difficult for the anesthesiologist to ventilate for them, to breathe for them. So sorry. So sometimes those types of things may make it not a good idea to do something, especially if the tumor is small. Another issue may be that they may have poor renal function. So most of us have 2 kidneys. And so your overall kidney function is based on your 2 kidneys. But what if your kidney function is not that great, even with those 2 kidneys? And now we do surgery and take away one of those kidneys. You may not have enough kidney function to stay off dialysis, okay? So, and then people tend to not do so well for so long on dialysis too. So if that is an issue and the tumor is small, it may not be the best thing. So that's when active surveillance is a good strategy. And so some of the tumor-related things that make us consider active surveillance would be, you probably can't see this so small. So tumor size less than 3 centimeters. So that's a small tumor. That's about the size of a golf ball, okay? So if you got a tumor that's 3 centimeters, that's confined to the kidney, especially if we've done a biopsy and it shows it's like low grade or something like that, then we may want to watch that, especially if some of these other issues are at hand as well. While we're doing active surveillance, we want to look at the tumor growth. Is it growing less than 5 millimeters per year? If it is, it's growing pretty slowly. That's half a centimeter. So if it's growing less than that a year, that's reasonable. We can continue to follow that. But if it exceeds that growth, then that might be something that makes us want to do something about it. Jayla mentioned cysts in the kidney. So cysts are tumors. It's just a cystic tumor. Cysts have fluid in them, but cysts can also be complex. So they can have fluid-filled areas, but they can also have solid-filled areas. So they can be complex cysts too. And those solid areas in the tumor sometimes harbor cancer cells. And so if a tumor is of low complexity, it may make sense to watch it. Thank you. So if a tumor is of low complexity, it may make sense to watch it. But if it's very aggressive looking, it may not make sense to watch it. All right, so that's active surveillance. So that's a strategy for managing kidney cancer as well. So I just want to give you guys some ideas about other management strategies besides just surgery, okay? All right, so let's talk about surgery a little bit. So we can either take a whole kidney out, or we can take part of a kidney out. So partial nephrectomy means we're going to take out the tumor itself or just the part of the kidney that's containing the tumor. And so you see this little picture over here where there's a tumor here right on the kind of the outside of the kidney. It's almost like as if your ear was hanging off of your head, okay? That's considered exophytic. So in those cases, many times we can go in and just cut the tumor out. And we always want to get a little bit of a margin. You see the little pink area right below the tumor? That's normal tissue. We always want to make sure we have a little bit of normal tissue on the backside of that tumor that we remove to make sure that we have what's called a negative margin, so we don't leave any cancer cells behind. So in partial nephrectomy, you put clamps on the vessels that feed and drain the kidneys, you cut the tumor out, you sew it back up like that, you take your clamps off. All right, so partial nephrectomy is recommended or considered for people with very small unilateral tumors. So unilateral means on one side only. Remember, most people have 2 kidneys. So if you have a small tumor on one of the kidneys, other kidneys good, maybe just take off that one tumor and leave that kidney alone, and then they are able to preserve as much renal function as possible. Another situation where you might want to consider a partial nephrectomy, if there's a solitary kidney. That means a person only has one kidney, and that could be because they already had one removed. It could mean they were born with one kidney. It could mean something happened to the other kidney, but they have one kidney now. And so if we go take that whole kidney out, there they are, they're on dialysis, okay? So if it's a small tumor and it can be reasonably easily removed by just taking the tumor out itself, doing a partial nephrectomy, that makes sense. Then that person is more likely to be able to avoid having to be on dialysis. Also, you may consider partial nephrectomy again with renal insufficiency. So somebody has overall kidney function that's not so good. Both of their kidneys working together is just barely keeping them off dialysis, so to speak. Well, if we take one of those kidneys, they're on dialysis. So in those cases, we may want to see if we can try to do a partial nephrectomy and preserve as much kidney function for those patients as well. Also, there are situations where both kidneys, so bilateral means both sides. So in both kidneys, there could be renal masses, small renal masses. And in those cases, hey, again, if we take both kidneys, they're on dialysis. If those kidneys can be managed somehow with partial nephrectomy, then we save or preserve as much renal function as possible. There's some familial renal cell carcinoma syndromes that people can have, something called, like there are lots of them, but one that I'm very familiar with is von Hippel-Lindau syndrome. And that's a familial renal cell carcinoma syndrome where these people are prone to making tumors in various parts of their bodies, especially kidneys. And they'll have multiple tumors in both kidneys. And they keep making them till they come over and over and over again. I trained at the National Cancer Institute in Bethesda, Maryland, and we probably had the biggest following of von Hippel-Lindau patients probably in the world. People would come from all over the world, and we would take these tumors out of their kidneys. And we would always do partial nephrectomy as many times as we could. I've personally taken as many as 25 tumors out of one kidney, okay? So these tumors are they're like marble size sometimes, and you just can pluck them out. But we want to do that as much as we can because we want to preserve renal function. And we could many times keep these people off of dialysis for many, many, many years before at some point the kidneys just had enough, because these people keep forming these tumors. They come back and then we have to take out another tumor. So, but anyway, as long as we can preserve renal function, that gives the patient a chance to stay off of dialysis. All right, and the other thing to remember with partial nephrectomy is that the cancer-related outcomes are similar for partial nephrectomy and radical nephrectomy. So they've looked at patients over the years, some of them who had comparable, say, tumor sizes, tumor grades. That's what we talked about, stage and grade. So now you guys know that stuff. People who have tumor grade and stage are the same. And they looked at ones who had their total kidney removed and ones that had a partial nephrectomy, and their cancer-related outcomes over time were essentially the same. So there was no real downside to doing the partial nephrectomy as opposed to the radical nephrectomy. So now, in my specialty of urologic oncology, it's pretty much a known thing that if you can do a partial, you do a partial, okay? All right, so let's talk about radical nephrectomy. Radical nephrectomy is when you take the whole kidney out, but not only just the kidney, you take out the tumor that's in the kidney, obviously, because it's in the kidney, but also the surrounding fat of the kidney too. So kidneys don't just look like this. They're surrounded by fat. If you open up the body, all you see is this big bag of fat around this thing, okay? It's true, and it's protective too. If you didn't have any fat around your kidney, if you got hit or something like that, you'd be more likely to damage your kidney. But it's like insulation, it's protecting that kidney. But the other thing that it does is, like, if a cancer is growing kind of in this, like in this picture right here, it's right on the edge of the kidney. Well, if there was no fat around it, then this tumor might grow right directly into an adjacent organ or to the muscle or something like that. But with the fat around it, it's like a barrier. So it can grow into the fat. And if we take the whole kidney out, then we've cured the patient, because by taking the fat, we took away that barrier around it too. So we can have a negative margin at the time of surgery. So again, taking a radical nephrectomy is taking out the whole kidney and also the fat around it as well. And so radical nephrectomy is recommended for tumors in general that are greater than 4 centimeters, as long as you have a normal kidney on the other side, especially because, the bigger the tumor is, the more difficult it is to do the operation and do a partial on it. But I put partial nephrectomy at the surgeon's discretion because, like I said, if you can do a partial, you do a partial, okay? Sometimes the tumor, even if it's bigger than 4 centimeters, if the majority of that tumor is like right at the top here, we'll just use this one as an example. You can probably see there's a blood vessel right here that's going right to the top of this kidney. And so this blood vessel is probably feeding the top of the kidney. So even if this tumor is bigger than 4 centimeters, if we can put a clip or a clamp across to this vessel right here, which basically stops blood flow to this part of the kidney, and then we cut across right here and sew this up, then we can do a partial nephrectomy on this tumor, even though it's bigger than 4 centimeters, okay? But there's some situations where it's complicated because the tumors are so big and they're in a spot that we can't really do that. So if this same tumor was smack dab in the middle of this kidney, there's no way for us to cut this tumor out and save this kidney, because these blood vessels are running right to this spot, and then you basically kill the kidney while you're trying to take the tumor out. So in that case, a radical nephrectomy is what you have to do for that situation. And if cancer has spread, Jayla mentioned that, so if the cancer is spread, then typically it's not curable, but it can be managed. And nowadays, with different drugs and stuff that are coming out, we're able to do that even better. And there was a trial that came out called the Carmenas trial, and they were looking at, if somebody has a kidney cancer, should you take the kidney out even if it's already spread? And when they did their secondary analysis, they found that, the people who actually really responded well to the chemotherapy and then had the kidney taken out, they did better, okay? But the ones who didn't respond well to the chemotherapy in the first place, there was no reason to take the kidney out because it didn't help anything. They didn't do any better. So in patients who have metastatic disease, who respond well to the chemotherapy, meaning that if they have like a lung area that has spread to, and that shrinks, or to the liver and it shrinks, they're responding well, then the patients do better overall if you can then go in and take that kidney out at that point in time. So that's radical nephrectomy. All right, so now some things that they didn't know I was going to talk about, needle ablative technologies or techniques. So this is important. So you can sometimes manage small renal masses by just putting a needle into that tumor and either freezing it, that's called cryotherapy, or you can ablate it with heat called radiofrequency ablation. And that will kill those tumor cells right there where it is in the kidney. And the reason that's a nice thing is that that patient then doesn't have to have a big operation because this can be done percutaneously, meaning that it can be done directly through the skin. The interventional radiology doctors can put needles directly through the skin into the kidney and do it that way. It can also be done laparoscopically where you use video cameras and small incisions at the time of an operation to do it too, because some of the tumors are not in a good location that you could do it percutaneously, but you could still do a laparoscopic approach. I used to do it, and I'll rotate the kidney around to where you can get to the tumor, and then I'll put the needle in myself and do it that way. But using these needles to kill these tumors allows you to many times spare more kidney function. So this is a picture where these needles are into this tumor right here. And it looks like this is probably a cryotherapy picture because it's white. That's how it looks. And so you put a gas through there called argon, and it freezes from the tip of the needle back. And so you can make a big ice ball around the tumor, and that kills that tumor, okay? And then you follow that over time because typically cancers, they light up on CAT scans and MRIs. That shows that they have good blood supply. And that's just kind of the key feature of kidney cancer. They're very vascular. They have a lot of blood flow to them. So when if you get a CAT scan or MRI and they give you dye in your veins, then those tumors light up when the dye hits them because they have so much blood flow to them. So once you've killed it by ablating the tumor though, on the CAT scans, they don't light up anymore. And that's how you know that it's done a good job. And then you follow these patients over time, almost like the active surveillance patients, and you're looking at the CAT scans and making sure that these things don't ever start to light up again, they don't start to grow again, and that's how you know that you've taken good care of it. One nice thing about ablation is you can repeat it too. So if it did start to light up again, or if it did start to grow some, you could ablate it again that way. And ablation is very good for small tumors, especially in a solitary kidney like we talked about. Somebody only has one kidney, you want to make sure you do everything you can to spare that kidney as much as possible. If you have small tumors in both kidneys, you can ablate and still preserve kidney tissue rather. If somebody's a very poor surgical candidate, then this procedure is almost essentially an outpatient procedure with the needles directly through the skin. They can go home the same day or many times. So, and also the other key thing where this is a good option, if there's a future risk for developing kidney failure. So Jayla mentioned some patients have kidney disease because they were smokers for a long time and those blood vessels have just gotten really narrow and the kidney is not healthy like it used to be, or long-standing diabetes or hypertension, then those kidneys may not be working very well and those kidneys are at risk for failing down the road. Then this is a way to not damage the kidney so much and preserve kidney function for as long as possible in those patients, okay? Now, one caveat though, you're not removing these tumors. And that's why I mentioned the fact that they can still live. You have to image them. You have to make sure that they are dead, essentially. Those tumors are, because this is less effective than surgery, okay? Than taking it out, all right? But again, you can repeat it. But then the benefit of this is there's less risk than surgery, okay? So those are just different ways of managing kidney cancer. I've talked about the active surveillance. I've talked about the partial nephrectomies, the radical nephrectomies. Now we've talked about ablation. And so the summary thing is that there are multiple non-medical therapies for managing kidney cancer, and they can be tailored to fit the needs and the overall health of the patient. That's all I got. Thank you all.